The recording.
Okay. Yeah.
All right, let's fire it up.
Okay. I think we're ready.
Good afternoon, ladies and gentlemen. We will be getting started as soon as folks finish joining our call today, our webinar today. Thank you for signing in. We have a good number of folks who are still coming on as I speak. All right, well, thank you all for joining us today. I know more will be joining us shortly, including one of our co-hosts who's attempting to get online with us as we speak. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I want to welcome you to today's webinar from Change Healthcare. Change is a longstanding member of the Health Data Consortium, and we are always pleased to hear from Change with respect to many payer and provider interoperability, data management, and similar technology and data related technologies and information. Today, we're joined by Cheryl Zarozny and Miles Caro, the VP of Consulting. Cheryl and Miles is the Product Manager for Change Healthcare. I'm going to spend a few minutes talking to you a little bit about sort of the rules of order and how we coordinate our webinars and how you can interact and engage with us. One is we have social media handles and hashtags. You could see MHDCs at MaHealthData. You can see Cheryl Zarozny at @SZarozny, SZAROZNY, and Miles at Miles Caro. You could see their organizational hashtag at @change_HC. And the event hashtags we have today are Change, MHDC Transparency, and hashtag Mass Health Data. So those of you who are social media inclined, those are available for your use. We also have a few rules of the road that we want to apprise you of before we get started. All attendees will be muted during the presentation. Please enter your questions in the Q&A window. We'll be keeping an eye on the Q&A. We will be taking momentary breaks during the course of the presentation so that you and others can have your questions answered. We are recording today's webinar, and the video will be available to all who are attending today in about 3 business days. In 2022, post-video hard copies and videos of the presentations will only be available to members. So we encourage you, if you haven't joined MHDC, to reach out to us, membership@mahealthdata.org, and learn more about how you can participate in our community going forward in 2022. We will also take a moment to complete a poll at the end of today's discussion so that we can gauge how well we're doing, provide our participants some useful feedback. The poll will be available to all to see online. So be mindful of your comments, but also truthful in terms of your comments and your impressions. Next slide, please. Just briefly about MHDC, who are we? We're a number of things. We've been around for 43 years, since 1978. We are an independent and unbiased 501c3 corporation, a not-for-profit organization that works with consumers, patients, members, individual people, payers, providers, government, industry associations, and technology services and professional services and other forms of healthcare services organizations. We bring the entire health data community together. We pride ourselves on our expertise in health data standards and regulatory developments. We have a local focus, but a national influence. We are increasingly addressing topics and covering issues that are national in their scope. And while we have in Massachusetts a great home base and a great test bed for a lot of innovation, innovation is happening elsewhere around the country and around the world. And lastly, we pride ourselves on taking ideas through the process to actual services. Our focus on services is on those services that are ones that fill the gaps. There are many places, many stopping points in the interoperability continuum where an individual organization can find themselves suddenly stuck, whether it's their data standards, their adherence to particular vocabularies, whether it's the use of the right APIs and the right underlying data structures. Many things can happen that can bring interoperability as we envision it to a halt. So we pride ourselves on developing and bringing to market those gap closing technologies that enable people to exceed the limits that sometimes off-the-shelf technologies cannot close. And lastly, if you change to the final page, Lynn, what do? We, in addition to this webinar, which you can see on the bottom right-hand corner of your screen, we have screen. I'll get my consonants right eventually. We also have the forum where we bring together CIOs, CTOs, and the technology executives in and outside of healthcare to deal with the challenges the industry must face. We have the Vantage Point series where we bring healthcare luminaries, people we are very, very impressed with, people who have dedicated their lives to healthcare and have brought to healthcare something unique given their purposeful missions and their dedication to healthcare. We've had Miki Tripathi, we've had Mark Gans of Cambia Health Solutions, we've had Alexandra Drain and John Glasser in 2021, and we have exciting people lined up for 2022. Within services that we provide to our members, we have data governance services that help organizations navigate setting data standards, adhering to data requirements for data interoperability as well as exchange. We provide exchange services as well through our merger with NEHAN, the New England Health Exchange Network. And lastly, we provide analytics services to payers and provider organizations using a range of data sets, including most recently, the Lown Institute data on equity, low value care, and health outcomes. And with that, I'm going to turn this over to Cheryl Zarozny, Vice President of Change Healthcare, and her colleague, Miles Caro, to continue our discussion at this point. Thank you very much.
Good afternoon. Thank you, Denny and Arlene, for having us attend today for this session. We're very appreciative, and hopefully we get a lot out of it. We're all in this together. I've worked with Denny and Arlene over probably the 30 years I've been in healthcare in Massachusetts, and it's been exciting that we've had an organization such as MHDC to work with in the industry. So they're doing a lot of great work. So as Denny mentioned, I'm Vice President Consulting Services for Change Healthcare. I'm a member of our consulting division, typical management consulting firm that works with payers and providers across the country. So a little bit about my background. I've been in the industry about 30 years, which I hate to admit publicly, working in multiple areas. I've worked for payers, integrated delivery networks, medical practices, vendor, obviously being at Change. So I'm going to let Miles introduce himself and then just kind of give you a quick background on what who Change Healthcare is in case you're not aware. So Miles, I'll turn it to you for an intro.
Thanks, Cheryl. I'm sorry about that. I forgot to take myself off of mute. I'm an account executive, and also I manage our product management team for the medical network of Change Healthcare. I've been with Change for a little over 8 years since graduating school, and I've really been focusing in on all things payer price transparency, and it's been an exciting time for our business unit with these upcoming mandates, whether it be the transparency and coverage mandate that we're really going to focus in on today, or the No Surprises Act. It's been an absolute pleasure getting to meet the team so far, and I look forward to this productive conversation. So Cheryl, I'll turn it back over to you.
Great, thanks. Next slide. So a little bit about Change Healthcare, just so you kind of understand the context that Miles and I are coming from. We're a leading healthcare technology and services company. We leverage various areas, our software and analytics, our network solutions, and our technology-enabled services to help improve efficiency, reduce cost, increase cash flow, and work to manage complex workflows for our customers. With our customers and partners, we look to create a stronger, better coordinated, increasingly collaborative, hopefully, and more efficient healthcare system for all of us. So a little bit of just statistics so you understand a little bit more about who we are. Over to the right, which I have you guys in the way. We have about 1.5, if I remember the statistics, I can't see it, 1.5 trillion in healthcare dollars. Miles, can you?
Yeah. Oh, sure. Absolutely. No, you're spot on. And then 15 billion in healthcare transactions. We handle 1 in 3 U.S. patient records, and we partner with, of course, over 6,000 hospital, 1 million physicians, 50,000 pharmacies, many labs, and we're connected to what seems like almost every payer around the country.
Great, thanks. I was able to move everybody's headshot out of my way. So really, this just shows the breadth and depth of the organizations that we work with, and all of that runs through our organization, through these main business units. And we're very happy to be partnering with probably many of the folks on this phone. Next slide. So one of the things that we always say, right, change is constant. It's part of our name, Change Healthcare. But in the healthcare space, we have all of these things continuing to come at us all the time. New entrants, new competition, system inefficiencies, all of the things that we struggle with being on the organization side with the payers and the providers. What we hope to do, and our goal really, is to inspire a better healthcare system and really help the overall ecosystem around reducing the healthcare costs, looking at building a connected system, and then focusing on outcomes. So some of the things that I think resonate for me, many years ago when I started in this industry, I worked at a payer. We were part of a payvider, so to speak, with a medical practice that was that owned the payer at the time. And my initial benefit plan, just for kicks, I went back in time and took a look at it. And I had $3 copays, $5 copays, maybe a little co-insurance if it was for chiropractic care. And that was about it. That was the complexity of the things that we were dealing with back then. And it was a sustainable option for young people, for young families with children, such as myself. It really was an environment that made sense. And the consumers weren't as involved in trying to understand this whole process, right? Fast forward today, 25, 30 years later, our yearly family deductible on the high deductible plan is actually more than we paid for the down payment on our house. And that's a little bit sobering to me, thinking about having 3 20-somethings as children that are adults now, trying to navigate through a lot of what we're going to talk about today, trying to understand their benefits, trying to understand where they should go for care, trying to understand what it's going to cost them. It can be pretty intimidating. So that's just sort of a look back and where we are today, and just the increase that we've all experienced, I'm sure, in that period of time. Next slide. So this particular deck, I'm not going to go through in detail, but these are some of the typical healthcare priorities that we're hearing from our customers and our clients as we work with them on various initiatives. We're also involved in a lot of different trade organizations that we work with them on in terms of what are their challenges, what are their issues. So things like system modernization, improved patient experience, really getting frictionless healthcare workflows. So these are areas that probably are all impacting all of you as well. And another independent organization that we work with is HCAG, Healthcare Executive Group. Actually, in 2020, noted #1 priority for them was consumer experience, which really ties to system and process modernization and automation, along with the patient experience. Their #2, you guessed it, was cost and transparency, and how, you know, they as member organizations can improve cost and transparency for their members, improve the member experience, the patient experience, do more with value-based care, and obviously the analytics that's needed around some of these more creative approaches to what we're looking to do in the future. All right, so on this particular slide, a couple of other things I wanted to mention, you know, just as a recent experience, personal experience. I have a 25-year-old daughter who went in recently. She had injured her ankle at Disney World on vacation and needed to go in. She wanted to be seen to have it checked out. So we knew she was going to have an office visit. We knew approximately what that was going to cost her. But while she was there, they came in and asked her to sign a paper. And the piece of paper said, you need an ankle brace, a piece of DME, and they were going to charge her $370. So at 25, obviously she got a little concerned and called me, and I walked her through the process and I explained what that was about. But I also told her, I said, it's kind of a steep price. Let's check it out, right? Don't agree to the DME. Let's take a look at what options you have available to you. And the long story short, we did some analysis, and quickly within the same day, we were able to get her a similar ankle brace, and it cost her $47 instead of her panicking over a $370 bill, which would have been less, obviously, with insurance, with the allowed amount. But that's a real life example of the younger folks trying to navigate through this process. So $47 ankle brace, she's totally fine today. And, you know, we really need to have this ability to shop, look at quality, and evaluate the best care for us and for our families. Next slide. Quickly about Change Healthcare Consulting, the group that I'm within, we have many different consulting focus areas. If anyone, you know, has any questions, certainly we can talk afterwards. But all of these areas are key to helping improve healthcare and working through the healthcare organizations, whether it's our main focus today, our healthcare consumerism piece, member engagement, patient engagement, and that sort of thing. And the price transparency coverage portion is really a positive step for consumer protection in healthcare. I personally feel it's something that's been needed, and we've made things so complex. It's really hard for the average person to understand what they're supposed to pay, what options they have available, and having ways to evaluate quality in such a way that they're able to pick something that works for them. One of the key things that I think here is that focus area to make sure that we are able as a industry to provide not just what's part of the regulation, but let's move things forward in a positive way. Next slide. Okay, so this is just a quick little slide about engaging the member, the whole journey, engaging the member receiving care, the member paying for care, and how transparency is going to fit into this overall journey. Why is this important? Definitive Healthcare, I have a couple stats, reported in March of 2019 that the increase in uninsured patients leads to more bad debt, right? Makes sense. In 2017, there was a poll done, and 37% of Americans said they would go into debt if they were faced with a medical bill of $100 or more. 37%, $100 bill, they would going into debt. A 2018 study from TransUnion showed that the patient balances after insurance grew by more than 52% between 2012 and 2017. This is an increase of 8% of the total bill to more than 12% during that time period. Also, in the same time period, Medicare bad debt increased by about 18% for a total of 3.7 billion. And the Medicare bad debt is just the deductibles and coinsurance the Medicare beneficiaries would owe. So clearly we have a lot of areas that we can improve, a lot of areas that we need to look at cost containment, along with quality, along with helping to educate consumers so that they're in the best place to take care of themselves and their families when it comes to receiving and paying for medical treatment. In terms of how we approach this, it's really about more than the regulation. It's about how we work to move the needle forward, integrate this with member experience and other strategies within the organization so that we can all gain more out of these rules and not just check the box as a regulation activity, but truly move things forward and make it better for all of our stakeholders. Next slide.
And Cheryl, before we jump into going through the transparency mandates or all the mandates that really apply to payers and providers, I did want to give the opportunity to the audience, and we will stop multiple times during this presentation to ask questions through the live chat feature, and that we can address as time goes by. So if there are any questions, MHDC team, I can't monitor the chat box on my screen as I'm sharing, but if there are any questions, we're happy to address them now. For the first portion of our presentation.
Sure.
Well, we do have, this is Denny. We do have one question that came across the transom. Cheryl, when you cited the shopping experience that your daughter was able to undertake, we have a question from one of our audience members that kind of shopping is not available to everybody. And when you think about the future and we talk about equity and we talk about accessibility of healthcare, perhaps you could shed a little light on what was for you a, kind of a step out of the box and go search on Amazon or whatever it is that the two of you did.
Right.
How that may become part of an experience that's more accessible to everyone.
Sure, Denny. Great question. I'm glad you asked. I wasn't sure how much information to provide on that example or how interested people might be in it, but that's exactly what I did. I told her, don't you dare sign any papers. I know you can't afford it. And she has decent health insurance and she's employed. I said, let me do some research. And that's exactly what happened. She did some research. I did some research. We found an appropriate alternative. I actually had called some local medical supply houses to say, here's what I need. Here's the situation. Worst case, I probably would have gone to Walgreens or CVS and gotten something temporary. But I called some medical supply houses. I looked online to their prices. And then we looked on Amazon, and Amazon Prime came through and she ended up getting the brace and using it for the allotted period of time. She still followed the physician's instructions. She just got a different model, so to speak. So, I do think those of us that are in the industry, do think and have options that we will try. And that's why I think educating the consumers and the members as we go through this process and really making it part of the consumer experience will be helpful because they aren't necessarily going to think, oh, geez, let me check Amazon or let me call a medical supply house. Let me compare prices for this piece of DME if I get it here versus at the physician's office. What amount of money am I comfortable with? I mean, it was really sobering to me for the statistic that, 37%, if they had a $100 bill, would put them into debt. People are too close to the edge when it comes to having money available for receiving care and paying for care. So it really comes down to that. The other thing I've worked with folks on is when you get that bill also, if you've got a situation and if you are able to pay in full, asking if there's a way that you can get some sort of a discount. So that was the other thing that she did in terms of paying for the physician charge was saying, I will pay it in full. Can you give me some sort of a discount for paying it all off instead of having to go on a payment plan? So there's a lot of education, I think, in a lot of ways that we can help the industry's consumers for sure.
And I'm sure one of the, I would just add to what you're saying. I think one of them will be that there will be apps using standardized data that will be accessible to people who have access to a mobile phone, a cellular or smartphone. For those who don't, it gets to be even more challenging. But we envision a future where comparative pricing for the boot, as was your case, would be available in an app or online as you completed your claim, and you would be able to purchase something that was less expensive at a competing price.
Right.
But
And the
thank you.
phone, yeah, sure. The phone still works too. I made phone calls to medical supply houses, so I didn't just rely on technology or my phone or the computer. So, we do have to take a look at, making it equitable for people to get that type of information. And I think depending on what you're going through, if it's an upsetting healthcare time, having maybe a family member who could kind of help you through that as well, because you may be, upset and not able to kind of think clearly. But I think there's a lot of ways that we as an industry can help them. And hopefully, the tools I think are going to be a great solution. And sometimes I'm sort of a high tech, low tech. Sometimes the low tech make the phone call also, so you can be educated helps.
Thank you.
Mm-hmm. Were there any other questions, Denny, that came in?
That's it for the moment. Thank you, Cheryl.
Okay. All right, great. Miles, I'll turn it over to you.
That was great. And one buzzword that I heard multiple times is accessibility. And really some of the driving factors of these federal mandates that apply to commercial health plans or really commercialized networks is around accessibility and providing access to a transparency solution to their entire membership so that they can evaluate costs prior to scheduling a service. This specific slide just encompasses not only the 21st Century Cures Act, but also the interoperability requirements. Those, of course, are phased requirements throughout that really kicked off earlier this year and will go for the next few years. And really the meat and potatoes of our conversation is centered around that red box, the price transparency mandate, connecting to member benefits, identifying gaps in care needs, and then finding the best care for that specific situation. And then keeping it all together, here's just some dates. Of course, 1/1/21, some of the interop, as I alluded to, interop has already started. There were some provider transparency deadlines or mandates that went into effect earlier this year. And then there is really a phased in approach for the payer transparency mandates that span not just from 1/1/2022, but there's new enforcement or new regulations that plans will have to comply to even as 1/1/2024 rolls around. So there's a lot to keep track of in the payer space, a lot of net new requirements, a lot of stuff that's net new for the industry. We're all in this together. However, I do believe Change Healthcare, being with the great team that I'm with, we have a good handle, a good wrap around the different industry needs in order to meet the enforcements or meet the regulations. So I'm going to center this conversation specifically around the transparency and coverage mandate and highlight the three-phased approach. Phase one that really goes into effect this coming January, but has an enforcement date of July 2022, requires 2 machine-readable files be posted on a public-facing website. Those files are the in-network and out-of-network files, and they include negotiated rates or allowed amounts across an entire network. In subsequent years, in January of 2023 and January of 2024, it's really centered around the self-service tool where members can log in and compare pricing on over 500 shoppable services defined by CMS for 2023. And then theoretically, they should be able to search for all covered items and services, so prescription medications as well, come January 2024 to make an educated purchasing decision prior to scheduling an appointment or filling a prescription. And as we think through accessibility and just some of the interesting survey feedback we've received over the last years, 81% of people that we polled think that shopping for healthcare should be as easy as shopping for other common services. And I completely agree. It's very much been in the mindset of I'm going to schedule this appointment and I might not know how much I'm going to pay until I get the EOB a few weeks after. Why can't we shop for healthcare just as we would when buying a new car or going to the grocery store? we know that the healthcare system is daunting and a little confusing. So here at Change Healthcare, we've really tried to boost the member experience so that anyone that's even just a little bit computer literate will be able to navigate on our multitude of platforms to be able to make an educated decision prior to scheduling a service. Of course, what's driving these mandates is consumers' expectations are evolving. And then Cheryl, pass it back to you just for a few more slides.
Sure. So a couple of interesting things today about the consumers and what they struggle with as they're trying to go through receiving care, paying for care, sort of the situation my daughter was in. At the end of that whole experience, I explained to you all, she still got a bill for $370 for the boot that she never accepted. So had to walk through that whole process, and it's very confusing, and it can be a daunting sort of experience to go through when you don't have a lot of the information behind how things are actually working. So right now, you've got 2/3 of the folks that feel that every step of the healthcare process is a chore, right? So clearly we've got some work to do in that area to streamline workflows, make it more efficient, make sure it's accurate. You don't get billed for something afterwards that you never received. You've got 62% that think that it's confusing, and I would say it's definitely higher with the younger generations, as you can see here on the slide. So some of our education points may need to be different based on the generation of consumers that we're dealing with. So we've got to look at it through their lens and make sure that what we're communicating to them is helping them understand what they need to do to be an active participant. And then 56% think that it's so bad today, they'll do anything to avoid getting care. So when you have that situation and avoid seeking care, we have what we've seen over the last year and a half, unfortunately, with the pandemic. You've got this pent up demand. People aren't going for normal screenings. So things that could have been caught earlier on and cost the ecosystem less are now going to be further along. It's going to cost the patient and the member more. It's going to cost the healthcare system more because they're trying to, not have to deal with it. They don't understand it. And by avoiding that care, it actually increases the cost for all of us. So that was really kind of the point on this slide, and really having us think about how we can take some of this information and make it actionable as we move forward. Next slide. So specifically on this one for the payers, and I know we may have some providers on the call as well. And there's both sides to it, and really both sides are part of the solution. But in terms of the recent industry analysts, really making sure that we take a look at how this is going to work from the front office through the consumer and the patient experience, both starting at the physician's side, what kind of appointments being booked, what do we expect the procedures to be, because that sort of information is going to be needed to understand what those costs might be. I do go to a provider practice right now that they will give you a sort of an estimated bill of what they think you're going to have. And that's fine unless and until when you're in the test. My daughter had gone in for some ultrasound tests. They added 2 additional tests while she was in there that they decided she needed. So the estimate we got beforehand wasn't reality at the back end. It was the best they knew at the time. So we are still going to have a gap there and need to do some work in that area and really look at the integration that it's going to take between understanding all the complexities around the payer contracts, the provider rates. Many organizations are doing a build versus buy decision. And as it relates to a build versus buy, you really need to, either way, there's going to be a lot of work around the integration. There's some great tools out there. You'll see an example today. And, in terms of that, it really comes down to, your internal organization, what your strategy is, where you want to invest your time and dollars in that build versus buy sort of situation. So I'm going to pause there for a minute and see if there's any questions, because I think after this slide, Miles, we may be going into the demo. Is that right?
That's correct. We'll focus in on really how Change Healthcare is helping payers meet these upcoming mandates.
Okay, Denny, any questions? I don't know if anything's come through.
There is one question that's come through from a colleague of ours, Ethan Fenner, who asks, it's one thing to improve the complexity, or to help navigate the complexity in our fee-for-service model, but how are we moving, and how does the work that Change Healthcare is doing move us toward value-based care? Move us away from the complexity that fee-for-service healthcare introduces, and allows us to get increasingly better, and allows the health system to be better at operating with risk in mind and with value in mind. Could you address that a little bit, how Change is helping the industry to move toward to value-based care, and how these services give organizations the ability to think in those terms?
So I'll take a stab at it, and then Miles, whatever you would like to add from your product slant. So a couple things. One, in terms of value-based care in general, and this doesn't have anything to do with price transparency, so to speak, but in terms of value-based care in general, we do have value-based care enablement services. It's outside the consulting team and Miles's product team. Our consulting team does work with organizations on value-based care. What does that need to look like? How do you deal with the quality issue? But in terms of our enablement services, they facilitate between the payers and providers to improve those patient care outcomes, and have tools and some products that are available in that space that help to move that along. So that's one piece. Within this topic for today, what I would say to that answer is that within our tool, we are working with payers to also consider quality as part of the metrics and what the consumer will see when they use the tool. So it's not as simple as, oh, go in and tell me what a 99213 code is going to cost me if I go here versus there. It's really going that extra step and saying, now let's layer in the quality, because that quality level may drive, I might think that I was going somewhere that I was comfortable with, but then I layer that in with these quality scores, and that's going to skew it. So as value-based care takes hold in some of these, having that ability to then show that quality piece along with it will bring the two together. I know Miles can speak more eloquently about the value-based care, or at least the quality piece within the TrueView product that we have.
Yeah, Cheryl, that's a great summary, and I was going to call out our value-based care services, but you're exactly right. As I look through these mandates, and we'll go through them a little bit more, and you'll have a better understanding once you see the live demo of our platform. Quality is not a component of these upcoming transparency mandates, but it is absolutely an integral piece of a member's purchasing decision. That's one component that we have added to our platform, as well as we have indicators on our solution that call out preferred providers or value-based care providers, call attention to these providers, and thus draw utilization to those providers or facilities of which you can get that great standard of care.
Great, thank you.
So we'll jump into really how Change Healthcare is assisting the payer market as they meet the transparency and coverage mandate. So I alluded to phase one as the machine readable component, where payers have to host their negotiated rates on a public website. We're partnering with payers in the industry to really consolidate and standardize their large data sets, and later converting that data into machine readable files. So we've created submission templates that are out in the market that really help guide plans as they gather those required elements, including the negotiated rates for the in-network or the out-of-network files. And then we can consolidate that data, create and make monthly updates to the files, and host those files on a public website. And an example of our public experience is on the right-hand side of this page, where we really white label, we brand it with a payer's look and feel for that seamless transition. And ultimately, as you really think about the intent of phase one, we're seeing these files can be upwards of 10 terabytes, which is many times over the amount of storage on my little laptop that I'm speaking to you from today. The intent is not for a member to download one of these files and gather true information to make an educated decision. The intent is really twofold. One is for data aggregators to come in amongst multiple payers' negotiated rates and create one sort of seamless, unauthenticated view of those rates between payers and providers. And the other intent of phase one is to set everyone up for success as we move to phase two and phase three in the subsequent years, as we will be driving a lot of our cost estimates found on these, based off of the rates found on these machine readable files. So we'll segue into really phase, yes.
Sorry, I wanted to interject. So
Please.
what we're seeing on the consulting side really is we've got sort of two camps. I don't know how people are, on this call, but really there's two camps. There's some who feel that they're going to wait till the last possible minute and not make this information out there available publicly until the July 1st enforcement date. And we have another camp of clients who are saying, it's going to come out eventually. We're going to work towards it. And as soon as we're ready, we will make it out available publicly. At some point, it'd be interesting to know where the folks on this call fall, sort of which camp they fall into. At the end of the day, as Miles said, the goal is to then be able to use this later for some of the consumer facing. But there's been an interesting discussions with several organizations in terms of where they're focusing their time and what they feel they want to put out in the public domain. And they're some of them are waiting until they're forced to do it. The hospital price transparency rule went into effect January of this year, where they had to have files on their websites. Now, Massachusetts has had a rule like that for many years. So for the most part, that was out there and available, but in other parts of the country, it wasn't. And it went into effect January 1st. CMS, I believe, went on a bunch of websites for hospitals like January 3rd and found, that like over 70% didn't have their files out there available for consumers. They did let it go, and they haven't, I don't believe as of yet, fined anybody, but they kind of started notifying people in the spring. So I think some of the payers may be looking at that saying, well, they're saying this date, but how strict are they going to be? So we may see some movement there, but, making sure that you're in compliance, but then also setting yourself up for this data to be used in a productive way going forward really should be the goal. Not just let's put the stuff out there and we don't really, we're not really going to be 100% sure if it's accurate, but continuing and continuous improvement, I believe, is going to be required as things get refined. People understand the data better, and they understand better some of the contractual things that might trip them up as they're trying to come up with their business requirements. So I believe this is going to be an evolution. It's not going to be a one-stop, boom, we did it, check it off, move on to something else. It's going to evolve, I think, for a little while. Thanks, Miles.
Cheryl, so I was, sorry.
No, I was just going to ask another question on this topic, which is, we've heard a lot about the machine readable file, and it sounds, sounds like a big, as you described, a big, chunk of information. Are there rules around which services need to be included? I know, look, next year or, January of 2023, we're going to have, a set of services that are required. But right now, what is this beyond a data dump? Is there some, you mentioned in the slide, standardizing these data sets and organizing them. If I'm an aggregator and I go to one health plan for their data, and then I go to another health plan, am I going to see two machine readable files that are organized the same way? Or am I going to be looking at two entirely separate instances of a whole lot of information put into a file that may have a comma delimited format, but may have different content or different services? Can you characterize what these machine readable files are supposed to look like, or are people given a pretty free rein as to how they're going to make these data available on their health plan websites?
Yeah, Denny, that's a great question. I'll start by saying that theoretically, these machine readable files should include all negotiated rates between a payer and provider for all services that they cover. We alluded to, shopping for a subset of services, and that's really a part of phase 2 with a different type of member authenticated experience. This data dump should include all negotiated rates between between a payer and all of its providers. As you asked about, will payer A's file look and feel different than payers B? Quite honestly, it may. CMS is given free rein into the formatting of these files as long as they are considered machine readable, which, like you alluded to, could be pipe delimited, could be JSON formatted. But essentially, because there are defined required elements that need to be included on these files, the data, all that data should be the same. Just the formatting should be, might vary.
Right.
Okay, thank you.
I think one thing I would add to that is, I think one of the things that I've seen is one payer may decide to break theirs out sort of at a high level and a product level. And then you have self-insured or TPAs that may break it out on an employer level. So I do think you will have, as Miles said, I think there's going to be some nuances. It's not going to be exactly the same. I think the data fields outside of how you categorize it should be the same. But you could have it broken out by product or broken out by self-insured employer potentially. I think some of those areas are really ripe right now to make sure that that's part of your data governance strategy around building these files. My group's working with some clients now, specifically. Do you have a data governance in place? Do you have a data warehouse? Have you thought about where you're pulling this from? Because you really need to go through that business requirements piece to then build the files that are necessary to support this. And then over time, as we learn more, I do think there'll be tweaks and nuances as we go.
A great resource, and I'm happy to provide our example submission templates to anyone that's interested after this call. Just feel free to reach out. But another great resource is there's a CMS GitHub, which is a collaboration space where CMS has provided additional guidance into very specifically those elements that are needed. And essentially, we have built our submission template off of CMS's GitHub, and we monitor it every week for net new updates related to the machine readable component. And last thing I'll say, Cheryl, we talked about the provider mandate earlier this year, and I was a part of that team. In fact, I was the product launch leader around this time last year, getting everyone ready for 1/1 on the provider side. You're right. There were written warnings for the first 4 to 5 months. Then that switched to $100 a day as a fine. And recently, I heard last week, rumor has it that the fine is now up to $10,000 a day for non-compliance for the provider transparency mandates. That's being monitored at the federal level. And one caveat is, as far as we're aware, of course, rules are subject to change, but phase 1 of this machine readable component will be monitored at the state level. I do want to segue into phase 2 and phase 3 and highlight our transparency solution called TrueView, which is a self-service, user-authenticated platform that allows members to view cost and quality information on over 800 medical services and 1,000 prescription medications. We have a wonderful user interface that I'll use to demo just in a few minutes. But additionally, we've partnered with multiple health plans that want more control over their member portal or user experience, and they consume our transparency APIs and make real-time calls to get cost and quality information and provide that back to their membership. This solution is actually the legacy Change Healthcare product. So when I joined Change Healthcare, it was a small startup. I was employee number 100. Since then, we have over 14,000 employees all around the world. But all that to be said is many of the same key team members that originally launched this product a decade ago are still with us today. So we have some of the best data experts in their field, and the routine monitoring of our algorithms and customer specific costs results in 97% accuracy, which is far above industry standards. And then additionally, the TrueView solution, which I'll demo for you in a quick second, was voted #1 in healthcare price transparency by KLAS in both 2018 and 2019. KLAS did sunset this category in 2020, but I'm emailing them on a monthly basis, trying to see if they'll begin reviewing transparency solutions due to these mandates, as I firmly believe we would still be on top, or we still are on top. So I'll jump into the live demo. Our preferred method of integration is really through SSO, through a health plan's member portal. We do allow for direct login access, where at Change Healthcare would issue members their usernames and passwords. But through SSO, and it's one less barrier to entry. A member would just have to log in through their health plan and click on the transparency link on their portal to arrive at what you're looking at today, which is the landing page of our TrueView platform. Everything you see on the screen can be white labeled, so it can be branded with a health plan's look and feel to create that seamless transition from that member portal into our platform, whether that be a logo change or a color scheme change, formatting of each of these modules on our landing page. We have a unified search bar. Just after a single keystroke, we begin suggesting providers, prescriptions, and services. So you can search by name of service, description of service, misspell of service. You can search by DRG, CPT code. Our unified search bar is highly predictive and can be found on each page of the platform for easy navigation. Down below, we have our My Plan feature with this speedometer. So through an eligibility API call, or through the 270, 271, we can pull in a real-time status related to a specific member's deductible and out-of-pocket maximum. And what's not shown on this demo is we can also integrate with a preferred HSA vendor and pull in the member's accurate to-date HSA balance. And this My Plan feature gives members their full financial picture prior to searching for a cost on our platform. Down below, we have customizable content tiles where everything from the image, the language, and the link can be highly personalized. We give ownership to this space up to our health plan customers or TPA customers to promote maybe their telemedicine provider. They may want to link back out to the provider directory or highlight an initiative outside of price transparency. And last but not least, we do have testimonials. Our testimonials range across our entire customer base. However, usually a year post go live for an individual payer, we will use our engagement components to survey their population and substitute our generic testimonials with really member-specific testimonials from other members on that same network that are accessing this platform. So I'm going to search for a knee replacement. With let's see here. Notice, there we go, perfect, just needed a refresh. The name of a service, a price range based off the total cost, as well as a customizable description for educational content on what really is a knee replacement. On the left-hand side, a member can filter between the distance and then really quality information. And then there's a multitude of sorting options, whether it be lowest cost, location, alphabetically, quality, and most relevant. And I'll get to what that means here in a quick second. Looking at a specific result, there's a provider at a facility, location, contact information, quality. You can expand the details for bundled services and see what goes into a specific bundle. Should I get a knee replacement with Dr. Brown at Memorial Hospital? We highlight the total cost, what the plan would pay in this instance and what the members out of pocket would be. Of course, with the knee replacement, this might be meeting the out of pocket max or the the deductible out of pocket maximums. So you'll see the member out of pocket estimate does not vary on a high cost service like a knee replacement. We have these preferred provider bars, which are included on multiple providers, and that's an indicator that we receive from our payer clients that say we want to drive utilization to this practice or provider group or facility. And when we indicate that a provider is considered preferred, when sorting by most relevant, which is one of our default options, regardless of the total cost of the service, the preferred providers will always appear at the top of the result set. So as we circle back to the value-based care and thinking of driving utilization to those high quality type providers, this is one tool that many of our payer customers utilize today to drive utilization. Additionally, we have badges where we can highlight tiered networks or benefit exclusions. We can also even throw in an image should you want to highlight or throw in the logo, in this instance of Park Ridge Medical Center. I would be remiss if I didn't quickly highlight our quality components, and while quality is not a part of these mandates, it is, as I alluded to earlier, a major factor in a member's purchasing decision. So we've elected to display clinical-based quality and stay away from those open text ratings and reviews. We can adjust custom quality on both the provider and facility sides that our payers may provide to us, but I will highlight where our default quality is sourced. So on the provider side, it's sourced from 7 proprietary databases internally here at Change Healthcare that we leverage amongst multiple products, and that's updated monthly. And then our facility quality is exclusively powered by CMS's hospital compared data set. Very simple. That is all we look at for facility quality. And I have the firm belief that that is some of the best facility quality available today. And to this date, 100% of our customers are aligned that's the direction we should move forward with facility quality data. If a member is looking for more of those open texts, how's the breadth of my provider comments, we do provide additional information and can link out to Google, Healthgrades, and Yelp. And essentially, it will open up a new tab in a browser where a member can read those comments or add one of their own on those platforms.
I should have called you, Miles, to look up the ankle brace for my daughter.
That would have been a good idea. That would have been a good idea. I have a couple of questions that have come back just as you were showing this, Miles, which is, how do you get the provider pricing info? Is that from the patient-facing API or providers' submissions to health plans via FTP? How does that happen?
It's a great, Denny, it's a great question. Let's take a step back. 10 years ago, when Change Healthcare started, it's all around price transparency. What's the buying mindset for a payer? Why would a payer want this solution if there's no mandate? And it was really a member engagement play or an ROI play, but it was hard to find accurate data at the beginning because payers said, we love the idea of price transparency, but we do not want to give you our negotiated rates. Those have historically been locked behind a safe with a key that we've thrown away, and no one's looking at those. So what we decided is that we were going to look through historical claims data. We look through maybe 2 years during an implementation, and then we evaluate our costs on a rolling 1 year's worth of historical claims data to really evaluate and define what the total cost of a service would be for a specific provider at a facility. Additionally, we can ingest machine readable files, so fee schedules or negotiated rates. Now I'm moving maybe to 5 years ago where certain payers were allowing us to get more of their internal data. And as I look to really the phase 1 intent, moving to phase 2, and this platform I'm demoing for you today is really a phase 2 component of the transparency and coverage mandate. We will strictly be using those negotiated rates found on the first machine readable file to power the total cost estimate on this platform. A CMS is telling us we can no longer derive a cost based off of historical claims, and we must exclusively look at those machine readable files, where we're already well positioned today, as we've been doing that for multiple years, to ingest those machine readable files and go through the full transition from what is currently today around 80% of historical claims driven costs to what will be 100% machine readable file driven costs. Does that help answer your question, Denny?
Yeah, there's a corollary to this question, which has to
Sure.
do with the provider information themselves, the provider directory like information. Plans are supposed to provide two, in 2021, they were supposed to provide a patient access API and they were supposed to provide a provider directory API.
Right.
Are you using the provider directory to foot and tie the data that you have here for providers, or are you currently working to collect that data in a different fashion?
It's a great question. We are using that same information. Now, granted, I'll be very clear that this price transparency solution is not a provider directory. A member, when they log in, we've identified what network they are on, and there's no way for them to toggle between network A to network C for evaluation. However,
Okay.
we are still driving some of that provider information through those provider extract files that are needed on a provider directory per se.
Okay, thank you.
I think it's also fair to say that the additional provider directory rules around updates and making sure that if someone relies on the directory and they go somewhere, but actually the data was different, and all of that regulation around how often it's updated and the accuracy and all is really, that part sits under our No Surprises Act sort of product and services offering. So I would think as that sort of moves down the path, that's also going to improve the data for all of us, right?
Right.
Yeah, I would think so. One final question. I think you addressed this earlier, but I wanted to be sure. Most relevant is defined as those providers to whom the health plan wants patients directed for reasons of cost and quality. Am I to understand the reason why that was used as most relevant?
You're spot on, Denny. So most relevant essentially will promote preferred providers. And I failed to mention that this language, as well as this bar, is customizable. So should you have a partner telemedicine provider, we can drive utilization to that specific telemedicine group where they would appear at the top of a result set, regardless of the total cost. So it's just another way of setting apart a specific provider group or providers for certain services and driving utilization to those providers.
Okay, thank you.
Absolutely. I'd be remiss if I didn't also highlight our pharmacy searching capabilities, and the look and feel is very similar. So I've searched for atorvastatin calcium, which is the generic form of Lipitor. And on the left-hand side on the filter bar, you can actually toggle between the brand generic and therapeutic alternatives when available. You can also customize your specific dosage and quantity to what is prescribed to you. 5 or so years ago, we received customer feedback that we were limiting the number of dosages and quantities, and there might have been outlier scenarios where members could not account for their specific prescription when searching for a cost on this platform. So we made the product decision to show all dosage and quantities that we see come across on a claim, even if it's very irregular. So should I be taking an 80 milligram tablet 20 times a day of atorvastatin calcium, we can accommodate for that cost methodology. However, we do default to the most commonly prescribed dosage and quantity on the initial search. So for atorvastatin calcium, there's that same educational content, a description of the prescription. You can see we're using that preferred provider designation to highlight a mail order pharmacy or the preferred pharmacy, and our badges to even show in the Walgreens logo. Members can search through 30 and 90-day supplies, and most of this data we connect to a payer's PBM or PBMs, and they will provide us with all of the pricing structure for that PBM that we can then power on this platform. Additionally, we have the ability to also show cash price options through generic discount programs and educate a population on the fact that should I utilize this cash price option through buy low, my prescription for atorvastatin calcium may not be covered by my health insurance. I also want to highlight, sorry.
That's okay, Miles. So what I was going to say was while the pharmacy files for machine readable are on pause right now, that was kind of pulled out. Originally, there were the 3 machine readable files. That one was sort of to hold. there is a structure and there is a lot of good information that can be gained to also help with that member experience, create less friction for the member. Back to some of the statistics we looked at earlier around not wanting to deal with it, not seeking care, and being confused. This is probably one of the areas that also creates a lot of that confusion. What are you going to pay? You know, I in my prior lives have used those pharmacy discount cards because, to be quite honest, the cost through my insurance was exorbitant, and I was in between jobs and etc. So I think pharmacy, as we know, has gone crazy with costs through the roof, etc. So helping people get the medicines that they need to help keeping them out of the hospital and having those higher level incidents of care required is good for all of us. And yes, it does not count towards your out-of-pocket maximum. That is correct. I just saw that pop up. I made the conscious choice to use that discount card because I was in between jobs, and it was $135 if I put it through insurance and I had to pay for it to count to my deductible, or it was $30 if I used a discount card. So I consciously did make that choice, and
That's
I knew
right,
it.
Carolyn. And
I
that's
knew it
why.
wouldn't count to my out-of-pocket max.
And that's why we've included generic discount pricing, just to show the options that are out there and weigh your options prior to filling a prescription. I do want to circle back, Danny. You brought up a great question towards the beginning of this call that talked about accessibility and the fact that maybe there's a portion of this population that don't have access to a computer. Well, with these new mandates, there is a need to export a cost result set and then mail that cost result set to a member that may have requested. So come 1/1/2023, a member on a commercial health plan can call their health plan and request by mail a cost estimate for atorvastatin calcium. And a health plan has up to 7 days to provide that cost estimate back to a member via mail. And we have features that are currently in development that we, in fact, looking at what's today's date? It's perfect. By Friday, our print to PDF feature will be live on this solution, and we are partnering with our printing department here at Change Healthcare for the final snail mail delivery of a cost estimate to members that may request this information. And then additionally, this platform is mobile responsive, so members can log in via their phone or tablet, and it sizes down accordingly to whatever screen you are currently utilizing to look at this solution.
So since you brought up the snail mail real quick, just for folks on the phone, one of our business units within technology enabled services is called CPS, Commercial Print Solutions. And it's print and payment. We work with payers and providers. So if invoices need to be sent out for services received, or the payers are sending EOBs, whether these things are electronic or paper, they do print and payment in automated fashions, as well as in terms of collecting payments. So that's the group that Miles is talking about. So we do a lot of partnering internally as we build our products to see which other groups have pieces and components that we can latch onto, whether it's an API or a service that we're already providing in some way. And we get very creative, around thinking that through from a design perspective.
And Cheryl, I think of CPS as like the kings and queens of EOBs and health ID cards. And in the conversations I've had with them over the past year, they're extremely excited to also get involved into price transparency. I do want to highlight our engagement component. So as you think about this solution and how it will be available to a population, it's one thing to have it available and to include a little blurb and a benefit package, but it's another thing to drive utilization and really change a member's buying mindset and encourage them to shop for their healthcare prior to scheduling a service. So we have two forms of engagement, and our preferred method of contact is through email. So we have email masking capabilities. So rather than send an email from, let's say, transparency@changehealthcare.com, we can send an email from transparency@abchealthplan.com. And that again builds that brand awareness and trust, and a member opening up an email from their health plan or a business that they recognize, rather than Change Healthcare, possibly a company they're not familiar with. So we have two forms of engagement. Our first one being our Ways to Save program, where we look through historical claims data and we define cost savings, or we find cost savings opportunities based off the total cost of a service or prescription. So in this instance, this demo account is getting a 25-minute office visit at Holston Medical Group for $138, where the plan would pay $110, the member out of pocket is $28. We have a bunch of different suggestions, as we've seen other members on the same network in the same general geographical location are actually spending less for that exact service. So we can use, let's say, Skyridge Clinical Associates as a good example. Should I want to make the switch, or should this demo account want to make the switch from Holston Medical Group to Skyridge Clinical Associates? There's almost a $50 difference on the total cost and a $10 difference on the members out of pocket per visit. So there's a 3-step process of making a call, and here's the phone number, scheduling an appointment, and just some educational information as well. In-app scheduling is a feature on our roadmap that we are slated to begin development on early next year, January, February of next year. I will be very upfront and say that our first or second iteration of in-app scheduling will more than likely not apply to every single provider on this platform. It will be a daunting task integrating into multiple provider systems, scheduling systems. However, this will be an option for many different providers to schedule through the TrueView platform itself.
So that will be another way that we're helping to reduce that friction between each of the steps that members are taking, and really, that overarching goal. When we were talking with other industry organizations like Healthcare Executive, really making that point of care accessible, and how we as an industry can improve that. And this is an example of that.
That's right. So essentially, we would love for this to be a place where you can shop and then book and then possibly even prepay for your service all on a single platform for easy accessibility and easy navigation through the healthcare system. One thing I want to call out is because our Ways to Saves are based off the total cost of a service, there could be instances where a member has hit their out-of-pocket maximum, and their responsibility would not change towards the end of the year. With those alerts, we also provide additional educational information on the benefits of really saving your health plan money, and how electing to lower the overall total cost of a service or prescription will help from premiums rising in the future. So just more education through our different engagement alerts all around, centered around all things healthcare. Our second form of engagement is our targeted engagement alerts, where we also look through historical claims data and really perform a gap analysis. So we'll define, let's say, a subset of a population, and let's say we want to target all men and women over the age of 55 who have not had a colonoscopy, and these can all be customized, let's say 2.5 years. We reach out to them through our engagement capabilities, through email, highlight the benefits of a colonoscopy, drive utilization into this platform, from where in the inbox you can read how a colonoscopy can help prevent or find colon cancer. And from the inbox itself, we will show in-network providers that can perform that specific service. So you can think of our targeted engagement alerts as applying to colonoscopies, mammograms, flu shots, annual wellness visits. Our catalog is rather expansive, so we have over 60 different customizable templates that we work with our payers, marketing, and communications team to not only get approval, but to get edits and feedback prior to sending out to a population. And many of our alerts can really apply to an entire network, our entire population. So for instance, just last week, last Thursday, we sent out an alert to one of our customers' membership on the benefits of an ambulatory surgery center versus a standalone hospital.
So that's part of where the patient education comes in.
Right.
I think that I alluded to earlier in the conversation. It's not just about putting these things out there, but educating the patients, educating the members on how they can be an active participant in all the phases and getting care, paying for the care, going to the place that works for them, both cost and quality.
Cheryl, you're spot on. So as a Change Healthcare employee, we have relatively recently, we now power this solution for all of our employees here. And so I, for one, I'll peel back the curtain and say that I got a ways to save that highlighted that said, I can save money by switching my PCP. However, I've been seeing my PCP for quite some time now. I have a great relationship with him, and I don't mind paying the extra $15 per visit because of that relationship and trust I've built with him. And that's completely fine. There's ways to reject the savings or dismiss the savings, or we would not contact you about that specific service again for a full year. However, it's a great reminder that I have this tool available to me next time I have a large purchasing decision related to my healthcare. So the intent is not, we know that not everyone's gonna make a switch and look to just save money, but they will be reminded next time they have to get blood work done, or even like a knee replacement or hip replacement, or even something small as an office visit, because I've just moved, I'm looking to find a new provider. This tool will be available to them, and they'll remember how to get to it. There's a direct correlation between our engagement alerts and really driving utilization into this platform, where members can then perform a cost search. So I'll leave the demo up in the background. Danny, are there any additional questions? We have a few more slides on our PowerPoint I wanted to cover, but are there any questions on the demo?
At present, we're good, Miles. So why don't we
Okay.
continue, and we'll save further questions till when you're wrapping up.
That's perfect. And if anyone that's listening does have questions related to our platform, I'll leave it up in the background, and we can always go back. So included in TrueView is really a reporting portal that we give to each of our payer customers that helps plans understand how their members are utilizing the platform, so they can view what members are searching for based off of age, gender, and location. And they can also view how those engagement alerts truly boost member activity. We can define subgroups within a population to refine results to a greater degree. And additionally, we have the ability to really export and provide custom reporting data extracts that many payers fold right into their existing reporting portal that they use to monitor their member portal. This summary slide is a really good wrap up as we think through transparency and coverage and the solution I just demoed for you as to what is mandatory and needed on this platform to meet phase 2 and phase 3 of the transparency and coverage mandate, and then some of those value additions that we have included on this platform to really help shape that member journey, whether it be showing quality data, those member engagement alerts, the My Plan feature, which shows members their real-time status related to their deductible and out-of-pocket maximum, the ability to highlight those preferred providers for essentially driving utilization to some value-based care providers, with our educational content, our reporting dashboard. We also have a customer support portal where health plan customer support representatives can log in and really impersonate a member's look and feel of their transparency, of their individualized transparency instance. So should I call into my health plan and want a cost estimate, and I'm willing to take notes on the phone, someone can log in on my behalf and read off providers and those costs directly to me. So really bringing it all together is Change Healthcare is ready to support health plans and TPAs as they look to be compliant with the upcoming transparency and coverage mandate by leveraging our public experience for the hosting of the 2 machine readable files in phase 1, and then implementing TrueView, the member authenticated price transparency platform, for both phase 2 and phase 3. And then Cheryl, turn it over to you for closing statements as we're showing our contact info, and we're always available and happy to help and answer any questions anyone may have.
Right, great, thanks, Miles. So, in that vein, if there are any topics that are of interest to you or anything you want to hear more about, please reach out. You'll have the slides and our contact information, whether you want to drop an email or call us. One of the things hopefully that you gleaned from this is we do feel passionately about what we do. Change Healthcare is here to inspire a better healthcare system, but as in part of doing that, working with all sorts of other organizations to really educate and have all of us work together as a collective group to really move the needle forward and improve the situation in our healthcare system in the United States is really what's driving this. So hopefully you got some good points to ponder, things to think about for the future, et cetera. And, we look forward to any and all feedback. So please drop us a note. Love to hear, what your thoughts were, or even if there was a question you didn't want to ask in front of the group, that's fine too. But really our goal today here was to educate and kind of talk about our journey, what we've been seeing, what we hear in the market, and give everyone some things to think about and some takeaways. So Denny,
Well,
I'll turn it back to you.
Thank you, Cheryl. I'm going to start a poll here very quickly. So if people keep an eye on their screen for just a moment, we're going to launch a poll. And please provide us your thoughts, your comments to just 2 questions. We know that there are a number of folks on the line. We appreciate your time and giving us this input so that we can continue to provide you through organizations like Change and others, the best presentation material that we possibly can. Let's see, we're now 27 seconds into it. It looks like we have a few more folks who are coming up to answer questions. Let's see if we get any more remaining. All right, we're going to give you just a few more seconds. And we'll end the poll there. Thank you. All right. I want to thank Cheryl, you and Miles for a great presentation. This was very helpful. I think one of the things that I took away from it is that we're in kind of an iterative building process. We can't get too far ahead of the industry because, as you pointed out, the operational and back office integration issues that health plans are going to be encountering is absolutely, to say it's daunting is an understatement. Their technologies have never been meant to be presented to the edge of the organization, to the edge of the enterprise for use by the public, much to say by members or by particular users of their space, but that is becoming the case. And we think the approach that you're taking is a sensible one. We wish more health plans were preparing now and rather than waiting for minimum viable implementations in 6 months from now, because they may discover that they're insufficiently minimum or insufficiently viable, and that would be a problem. But we know Change to be a leader. We thank you for bringing to us and to our audience's attention the technology steps that you're taking to move this market forward. And I want to thank you again for joining us today and sharing your insights and those that Change is bringing to bear in its work with payers and providers across the market. And with that, I want to thank our audience. I appreciate folks' involvement and your questions. And at this point, no one ever missed a meeting that ended earlier, regretting that they didn't spend more time in the meeting. So I'll leave it with that. And thank you all. We're adjourned. Have a good evening and a good holiday.
You as well.
Bye-bye, everybody.